Welcome everyone to the MIDRC monthly seminar for June 2023. Today's topic is MIDRC and the NIH's data sharing policy. We are very happy to have Dr. Brad Bauer being our speaker. I am moderator. I am Maryellen Giger from the University of Chicago. Dr. Brad Bauer is an NIH Data and Technology Advancement National Service Scholar at NIBIB, a data scholar. His project includes identifying and advancing opportunities for interoperability across NIH repositories, including MIDRC, the Medical Imaging and Data Resource Center at NIBIB, the National COVID Cohort Collaborative, N3C, at NCATS, and the Biodata Catalyst at the National Heart, Lung, and Blood Institute, NHLBI. Additional goals of the project include exploring public-private partnerships in the data ecosystem and promoting the bench-to-bedside data lifecycle for AI product development in order to lower the barriers to commercialization of new AI-based products. Dr. Bauer has a diverse set of experiences in research, marketing, and leadership roles in medical device companies. These range from preclinical research and development to clearance from the US FDA, along with product launch and post-market activities. His prior work includes ophthalmic imaging devices, non-invasive concussion diagnostics, point-of-care diagnostics, and AI-enabled MRI-based predictors for autism spectrum disorder in infants. I welcome Dr. Bauer, and we will have questions after his presentation. You can put them in the Q&A in the Zoom at the bottom. Dr. Bauer?
Great. Thanks very much, Dr. Giger. Let me share my screen 1 second. All right. Thank you all very much for joining us today. I very much appreciate the MIDRC team setting aside a webinar series to talk specifically about the NIH data management and sharing policy. This is a relatively new policy. I think there's some confusion around how to implement it, et cetera. And I'm really excited to be able to speak to the policy and how MIDRC fits within that policy. As Dr. Giger said, I'm a data national service scholar with NIBIB. It's important to note NIBIB does support MIDRC, but I have no conflict of interest in this presentation. First, I think it'd be good to talk just a little bit about what NIBIB is. So the NIBIB is the National Institute of Biomedical Imaging and Bioengineering. Mission of NIBIB is to transform through engineering and understanding of disease and its prevention, detection, diagnosis, and treatment. NIBIB supports new tools and technologies to improve human health within its internal laboratories and through grants, collaborations, and training. The beauty of NIBIB is it's a very engineering-focused IC or institute and center within the National Institutes of Health. NIBIB has taken a strong engineering approach to things like COVID. We were really active in the response to COVID-19. A couple of links just to check out, which I think are very interesting. NIBIB was a large part of the Rapid Acceleration of Diagnostics, or RADX program, and the Make My Test Count program. Strongly recommend you check out this QR code. This is a fantastic way for people to actually report at home their COVID-19 tests, both positive and negative. This helps us get a much better understanding of population statistics around COVID-19. And we also have the NIBIB newsroom, where you can find various articles about programs at NIBIB. MIDRC is strongly featured here, and I definitely recommend you check out this article on fair and ethical algorithm development that features Dr. Giger within the NIBIB newsroom. So maybe let me take just a couple of minutes to talk about MIDRC. If this is your first time at one of our webinars, we'd like you to have a better understanding of what MIDRC is. So this was a response to the COVID-19 pandemic. And honestly, the motivation was we need AI forward medical imaging databases. So MIDRC really is a curated image and data commons. One of fascinating aspects of MIDRC is that it really is a partnership between the three leading professional societies in radiology. So we have the American Association of Physicists in Medicine, the American College of Radiology, and the Radiological Society of North America, really being supported by NIBIB and hosted at the University of Chicago on the Gen 3 Data Commons platform architecture. So this, from the outset, MIDRC was a very collaborative project, which by its nature is not typical for this kind of large curated data commons. There are a lot of benefits to that. There are two specific scientific components of MIDRC, the Open Discovery Data Commons, and really enabling machine intelligence computational capabilities through sequestration of data, which I'll talk about in a second. Like I said, MIDRC was part of the COVID-19 pandemic response, but as we move into 2023 and beyond, we start thinking about long COVID, which we know has characteristics that occur in multiple organ systems. And MIDRC is really expanding beyond just COVID. We're thinking about other organ systems, other diseases. So if you've heard of MIDRC before and you've heard of it associated with COVID, it's really important to note that while it is a fantastic resource for COVID, as we're thinking about the next steps for MIDRC, storing data, analyzing data, building algorithms around data for more than just COVID is really a part of our mission. MIDRC has grown very quickly in really fascinating ways in the last couple of years. We've ingested a total of 309,000 plus imaging studies. It's important to note that's an imaging study, not an image. Every imaging study may contain many individual images. We've actually released over 135,000 imaging studies to the public in the Open Access Commons, and over 27 or so algorithms have been built on this data. So when we say released by MIDRC, it's gone through a process of de-identification, quality control, harmonization, and maybe one of the most important parts of MIDRC is that 80% of the data that comes through MIDRC is released to the public in this Open Access Commons. 20% of it is actually held off in a sequestered commons. And the reason for that is we really want to have a pristine data set that has not been released to the public that's available for algorithm validation. So when we want to talk about performance evaluation on an algorithm, you can draw test cases from the sequestered data. And here we're talking about specifically sort of a task-specific sampling of that data. So for instance, we have a sequestered commons. We have a large amount of data set in there that's not been used for any kind of algorithm creation. Here we might have one task example is COVID positive versus COVID negative. Second task example may be COVID severity. And the distributions within these different tasks may look very different in terms of what we need to pull from our sequestered data set. So MIDRC has done this amazing job of building task-specific sampling that allows us to go through and say, okay, for let's say task example A, algorithm for COVID plus versus COVID minus detection. We can actually draw from that sequestered common multiple times. So we're not using the full data set every time. So we can actually validate multiple algorithms, multiple products with the same sequestered data set. So this really enables not just research and development, but a pathway all the way through towards the FDA as we start thinking about releasing clinical algorithms into the clinic. This is highly important for NIBIB. We're very interested in seeing products get to the clinic. And the MIDRC team has really done an amazing job of making sure we're not just stopping at a really good end result, a really good publication, but we're actually taking that all the way through to the clinic and FDA clearance. One other thing I definitely recommend you look into is the MIDRC AI and ML bias awareness tool. There's a QR code here for that. The MIDRC team is very interested in addressing bias and diversity in data sets. This beautiful graphic here actually explores all of the various ways that bias can enter into an algorithm development process All very important things that you should be considering when you're developing an AI algorithm. Please go check these out. All right, now to the meat of the presentation, the NIH Data Management and Sharing, or DMS policy. So this policy applies to all new NIH grant awards starting in January 2023. So if you are preparing to submit a new application or new proposal, you will fall under this guideline. You will need to comply with the DMS policy. And there's a QR code here that will take you to the full policy. I definitely recommend check this out before you submit your next proposal. The DMS policy is important, and we'll get into some of the details about that in a second. But this isn't something that can be done at the last minute. This really needs to be something that you've put some thoughtful consideration into, and hopefully in the context of MIDRC, we can give you some ideas about how to complete that. So under the DMS policy, NIH really expects investigators to submit a DMS plan when you apply for funding. Plan your budget to make sure there are actual dollars available for managing and sharing of data, and then you have to comply with the plan. So plan what you're going to do it, comply with the plan. It's important to check with your IC, your institute and center, about IC specific guidance or recommendations for DMS. There may be slightly different depending on which IC you're applying to for funding. So the process for DMS plans is in the pre-award phase. The DMS plan is part of your proposal. It is 2 pages. There is a DMS plan template. This is not a hard and fast form where you fill this out and you're done. It is meant to be a template. It is meant to guide you through the process. Your budget must reflect data management and sharing. These are typically direct costs. We'll get into costing in just a second. And the plan, importantly, is actually assessed by your program officer. So peer reviewers are allowed to look at your DMS plan, but it cannot factor into their final decision. The DMS plan is reviewed by the PO, and you may need to have conversations with your PO about the actual DMS plan. Post-award, this is really important. So in the past, yes, you have had to submit a data management plan, and that included things like management and sharing. With the new DMS policy, once the grant has been awarded, the plan becomes a term and condition of your notice of award. So this is actually binding now as part of your award. The plan can be modified with ICO approval. This means talk to your PO. Something has changed. Things always change. Technology has changed, et cetera. You want to change your data management and sharing plan, make sure you talk with your PO about that and get those changes approved. Compliance is reviewed when you submit your annual progress reports or periodic progress reports, depending on the nature of the award. And failure to comply with the term and condition of your award can result in new terms and conditions being applied to your award. And this can actually affect future funding decisions. So this becomes a very important part of your award. Allowable costs in a DMS budget. So the NIH really wants to bring data management and sharing to the forefront as we think about reproducibility and replicability of results. So this is not intended to be something that gets wrapped into your indirect costs. This is not facilities and administration. This is not, oh, it'll be covered in our institutional overhead. We'll sort of figure it out as we go. The NIH really wants to see a very clear plan for how data is going to be used, how it will be prepared for reuse. So things like curating data, developing supporting documentation, making sure that data can actually be used, definitely allowable. If you have specific local data management considerations, you need on-premise hardware that will allow you to have an environment in which you can prepare your data before you deposit it into an established repository. That may be something that may be allowed. And preserving and sharing data through established repositories. So there may be costs associated with preparing your data to get it into an existing established repository. Those types of things are allowable costs. So there is a QR code here. I recommend you take a look at that. It's important to know what will actually be included or what's actually allowable in a budget as we think about DMS. So an important question, what do I actually need to share? So you need to share scientific data, and scientific data as defined by the policy, read it verbatim, recorded factual material commonly accepted in the scientific community as of sufficient quality to validate and replicate research findings, regardless of whether the data are used to support scholarly publications. So even if this isn't published, if the data is required to validate your results and replicate your results, it counts as scientific data. Now, we don't want to boil the ocean here. Scientific data doesn't include things like laboratory notebooks, preliminary analyses, that one file that's on that one grad student's laptop that is not necessary, probably not scientific data. But if it's necessary to validate and replicate your findings, it is. So we need to be thinking about what counts in your lab. What if you have human subjects data? Very important question. NIH prioritizes responsible management and sharing of scientific data derived from human participants, effectively follow applicable federal, tribal, state, and local laws, regulations, statutes, and guidances, and institutional policies regarding human subjects participation, et cetera. An important note here is as you think about your informed consent process, ensure that there's some text there that describes how the data management and sharing will be addressed. It's important that subjects have the information around how their data will be shared in the appropriate way for applicable guidelines. And now, where should you share your data? Data repository selection, NIH strongly encourages the use of established repositories to the extent possible. This was not, this new policy was not an intent to get people to go and roll their own repositories and create lots of new methods for data sharing. There are already some really fantastic, well-established repositories. MIDRC is one of them that NIH encourages people share their data in. So as we think about selecting a repository, and I encourage you, please go to the selecting a repository link. This is on sharing.nih.gov. And actually contains some resources around what's an appropriate repository for my data. So as we think about what is the right repository, the Research Data Alliance put together these trust principles that are around transparency, responsibility, user focus, sustainability, and the technology. The Office of Data Science Strategy at NIH expanded upon the trust principles and put together a set of 12 desirable characteristics for all repositories that I suggest you think about as you're trying to pick the right repository for your data. So they include things like unique persistent identifiers, long-term sustainability. Will the data be there as long as we think it will be? Metadata management, curation and quality assurance. Is the data in such a way that people can actually reuse it? Free and easy access, broad and measured reuse. How do we know people are using the data? Clear use guidance, security and integrity, confidentiality, common formats like DICOM, provenance. Can we track what has happened to this data, how it's been manipulated, how it's been used, et cetera, and the retention policy. So important factors, and we'll revisit these in just a couple of minutes as we think about these factors in the context of MIDRC. So for just a second, I'd like to go into the actual facets of the data management and sharing template. So again, the guidance is here if you'd like to take a look at it. It effectively addresses things like data types, the types of data that you're actually generating, what is the scientific data that you intend to generate? Remember that definition we just talked about. What are the tools, software and/or code that were used to generate this data? Again, the focus here is replicability and reproducibility. I want to know how I can take your data, how it was generated, and how I can use it to generate the results that are in your publication or report. What standards might apply to the data? Are you using a particular data model? If so, what is that data model, et cetera? Data preservation, access, and associated timelines. Now, these factor more into repository selection. So if you're picking a particular repository should have good answers to number 4 and number 5, access, distribution, or reuse conditions. This includes things like, is it controlled access data? So if you intend to share PHI, it needs to be controlled access data, almost certainly. And then oversight of data management and sharing, we'll touch on that towards the end. This is really up to the PI and their institution. So let's go through each of those one by one, and I'll give you a little bit of the response of how MIDRC would address this. Data type really is unique to each study. MIDRC ingests and curates DICOM data from standard clinical radiological imaging. That's really the sweet spot for MIDRC. MIDRC can ingest any size data through our curated American College of Radiology or Radiological Society of North America channels, meaning effectively that those societies are performing the steps of de-identification and curation of your data before it gets to MIDRC and publicly released. We do a lot of ensuring that that data is AI ready, and it's through these ingestion channels, or through a Gen 3 channel where we have a little less curation. It's a little more freeform in terms of how it can be stored. Scientific data that will be preserved and shared, and the rationale for doing so. Again, this is unique to your study. As we talk about sharing, we'll touch on this again, but MIDRC can mint DataCite DOIs or digital object identifiers that can be included in a publication and associated with your scientific data. Metadata, other relevant data, and associated documentation, again, unique to each study. MIDRC curation channels actually map metadata to LOINC codes using the RADLEX playbook. So we have ways of looking at things like study description and standardizing that information and harmonizing. Related tool software and or code. I give this specific text from the policy here. Just something to note that MIDRC contributors can share software and algorithms on the MIDRC GitHub page. And that as the DOIs are minted, landing page with the DOI, and should cite the publication and methods used to analyze the data. So if you want to point back to a particular GitHub page or Hugging Face or something for a model, we can do it through that DOI page. Standards, unique to each study. MIDRC encourages a fair approach to data, which is findable, accessible, interoperable, and reusable. And MIDRC uses an OMOP data model and standardizes the descriptions to LOINC codes. All right, repository where scientific data and metadata will be stored. Medical Imaging and Data Resource Center, MIDRC, was created in 2020 and is supported by NIBIB. How scientific data will be findable and identified. Again, this is all, number 4 has multiple aspects to it. MIDRC response. MIDRC has an extensive search utility and cohort builder, very easy to go in and find the data you're looking for your algorithm you want to build. As well as, again, MIDRC mints DOIs for data cohorts to make data easily findable. Data preservation, access, and associated timelines. How long will scientific data be available? I don't think any repository is a guaranteed indefinite lifespan, but MIDRC is strongly supported by NIBIB and anticipates continued funding through mechanisms like NIBIB support. Access, distribution, or reuse considerations. MIDRC mints DOIs, makes them easily findable and identifiable. Whether access to scientific data will be controlled. So MIDRC is actually an open access repository in data commons. We don't control access. There is, if you want to download data, you have to sign a use agreement. This actually essentially says this is for research purposes and not being used for a commercial purpose like reselling the data. MIDRC does require user registration and login if you want to really download data, dig into the data using the data portal. Protections for privacy rights and confidentiality of human research participants. MIDRC has a validated de-identification process through ACR and RSNA. And we also have all data hosted publicly on MIDRC and sequestered for algorithm validation is de-identified. Very careful about this. Part of the curation process is ensuring that data is fit for public consumption. Oversight of data management and sharing. Again, this is unique to each study. You're going to need to define how your institution wants to ensure that compliance is maintained. So a couple of questions, and then we'll close in just a second here. Is MIDRC right for my data? Very common question. MIDRC ingests, curates standard radiological imaging, DICOM data, for example, CT, X-ray, MR, ultrasound, as well as basic demographic information for the data. We'll be releasing a decision tree soon on the website, midrc.org. You can check that out, and it'll help you decide, is MIDRC the perfect fit for my data? In addition to my imaging data, what if I have behavioral surveys, I want to figure out how I can put all of my data together. Really, the best option here is contact the MIDRC team. There are multiple ways through the website you can reach out to us, but specifically to see if it can accommodate your data, make sure you reach out to us. Does my data have to be COVID data? Absolutely not. So COVID was sort of the first use case for the MIDRC concept for medical imaging data prepared and ready for AI with sequestered data for validation. And it was a very good use case and very timely and very necessary. But as MIDRC continues to grow and expand, COVID is certainly not the only use case. Absolutely, if you are not working in COVID, please contact us. It may be a perfect fit for your data. Additional considerations for the DMS. Budgeting, the MIDRC website decision tree tool will help you understand your fit. We just talked about that. MIDRC staff can work to help you draft a budget template. So we can talk to you about what is it actually going to take to get the data in MIDRC. Do you need to add additional costs, et cetera? And just a couple more notes on the review process. We talked about the fact that the PO reviews the DMS plans, including the budget. I've been at multiple meetings over the last 2 weeks with POs who said that they've expressed concerns because they're seeing things like a $0 DMS budget, or will share as appropriate. If you read the policy, these things are specifically frowned upon. You really need to be thinking about how is my data going to be shared and address that appropriately. So just to touch on the 12 desirable characteristics briefly, unique persistent identifiers, we cover that through DOIs and also GUIDs through the Gen 3 platform. Long-term sustainability, MIDRC has NIBIB support. Metadata, we do things like link mapping of study descriptions for metadata is well searchable and identifiable. MIDRC really shines in curation and quality assurance, and from the various repositories that I've seen across NIH, I think is certainly a leader in how we're managing data that's coming into the repository. Free and easy access, MIDRC is open for use, very much stressing the idea of equitable access to good, well-curated data for AI algorithm development. Broad and measured reuse, we actually get this in a sense through DOIs. Clear use guidance, all data is accessible on MIDRC through open access. Data contributors agree to make the data available for open access. Security and integrity, MIDRC is built on the Gen 3 Data Commons, which is FedRAMP, which is a FedRAMP authorized environment. This means that we have high security standards for the MIDRC backend. Confidentiality, all data is de-identified. Common formats, we're accepting DICOM data specifically, and then metadata associated in terms of like demographics and that sort of thing. Provenance, MIDRC tracks data ingestion, so we know where it's coming from. We have a clear record of who contributed what data within our system. And the retention policy is data is effectively retained for the lifetime of MIDRC at this point. So if you have any questions, we're happy to field those now. Dr. Giger is going to moderate. My contact information is here. You're welcome to reach out to me. I very much encourage you, check out the MIDRC NIH data sharing response. The link here and the QR code is here. A lot of valuable resources on the MIDRC website. And thanks to really Dr. Giger as the contact PI and the entire MIDRC team. This project is important for NIBIB. It's been very important in COVID, and I'm excited to see what else we can do with MIDRC as we expand beyond COVID. Thank you very much for your time.
Thank you, Brad. That was fantastic. And I think probably opened the eyes of many on what they need to do as they write their next grant. We do have a few questions.
Great. So
in the Q&A, we have one: what role does PHI de-identification play in this requirement specific to MIDRC?
Specific to MIDRC, I would say, MIDRC is an open access commons. So the data will be de-identified before it is submitted to MIDRC. There are not specific requirements around PHI and the data management and sharing policy, but I would suggest you read the section of the policy on human subject scientific data. and making sure that you're complying with local standards, federal standards, institutional standards, et cetera, including HIPAA, including the genomic data sharing policy around how you're actually managing that data. So if you want to put your data into MIDRC, we have a policy for de-identification of that data to ensure that PHI is not actually present in our system, that the data is purely de-identified. Yeah, I hope that answers the question.
Yeah, and they may, you think, need to check with their IRB
Absolutely.
at their institution,
Absolutely.
which our contributors do currently. Oh, and we have another question. Do any of the DMS requirements apply to NIH intramural research? Do they have to share also?
I believe the answer to that is yes. Without directly pulling up the policy, I know the policy specifically calls out extramural, intramural, and contract partners for the NIH, and they all have specific sections of the policy that they need to address. Or I'm sorry, there's a specifically called out in the policy is in the need and how they need to comply with the policy. So I would very much suggest you check that out.
Thank you. And we have another one. We have two more. If data on MIDRC is for research purposes, then can you clarify how MIDRC can help commercial translation? I think they're referring probably to the sequestering aspect.
Sure. I will take a first pass at this answer, then I'd like Dr. Giger to answer this as well. So there's an aspect of commercial product development where you're sort of in the pre-competitive space and effectively performing algorithm development. So there's a lot of work that can be done on initial algorithm development that may be possible on research type data where you're effectively still performing research. I've seen a lot of back and forth about what is commercial versus what is not commercial. Certainly, if you are in a commercial setting, contact MIDRC. Let's have that conversation about what is a valid use of the data. The policy that MIDRC has been complying with is effectively no resale of the data. But generally, when we've been talking with potential commercial partners, we've discussed the possibility of using the data to train models, et cetera. Now all of this may change over time. Certainly, I'd say reach out to MIDRC to discuss that policy. Yeah, Maryellen, how would you approach that?
I agree with that. If you're using it for research in your company and you want to use it to work on training, evaluating your systems, but as long as you're not putting those images in your commercial system that's being sold. Now, the other way we help you as a member of industry is, as Dr. Bauer talked about, with our sequestered database. So roughly 20% of the cases that we bring in are sequestered. And what that means is if you have an algorithm that you feel it's ready, you want to go to FDA, you bring it to MIDRC, we're arranging where we would test it inside of MIDRC on our sequestered data set. Our sequestered data set matches the characteristics of our 80% that are the open data set. But the sequestered data set, no one touches. We can bring your algorithm in. We're working on methods for containerization, evaluate it, and what we would give you is some kind of summary of performance. We won't tell you how each case performed because we need to retain the integrity of our test set. And based on your claim, your clinical question, and your intended population, we will draw such cases from our sequestered tests, our sequestered comments to test your algorithm. And if you were to come back again, we would redraw such cases. So we again retain the integrity of our test set. So there's two major ways how we want to help industry and expedite getting AI algorithms to the public for clinical care.
And if I may, I think one really important point here is this is not just sort of lip service around, we want things to be FDA compliant. Folks from the FDA have been engaged with MIDRC pretty much from the beginning. On the NIBIB side, we have collaborations with the FDA. On the MIDRC side, we have collaborations with FDA, specifically to ensure that these sequestered data sets actually meet the need. as we're thinking about real world data, real world evidence, algorithm validation, this is not MIDRC developing these concepts in a vacuum. This is MIDRC working directly with the FDA to ensure that what we're building is useful and actually going to lead to product clearance. And again, this is a distinguishing aspect of MIDRC that I've not seen elsewhere.
Yes, and also if you go to the chat, Katie Pizer has put the link to our DUAs, data use agreements, and there's one for academic researchers and one for industry. So if you read those, if you have questions, please contact us. There's another question. Can you comment on how annotations or labels used for supervised learning are integrated with image data in MIDRC? Another good question. So here, we are working to annotate all the data in MIDRC. Now, if you're donating data through for your grant, for your data sharing, and you have annotations, please submit those also as metadata when you submit the imaging data so that others can use them, others can validate them. So yes, we do want annotations as metadata in the data sharing. And within MIDRC, we also are working to provide annotations. We currently, for the COVID positive negative cases, we do have labels on, is this a COVID case, a positive case or not? And then based on dates of the COVID test, dates of the imaging exams, because for a given patient, there'd be multiple ones, you can relate whether or not that image is in, say, within 2 days of a COVID test. So we have those kind of labels, and we have our data model is ready for both image-based label, case-based label, and pixel-based segmentations. So we're ready. Other questions, let me see. Let's see. Oh, and we don't, but I have one for Brad. We've always, and I know you've touched on this nicely in the talk, but I think it's so important. I just want to bring it up again. We've always had a data sharing component in our grants that we submitted. So many people say, oh, I've already done this, but there's some really subtle and important differences that we have now. And I think it's worthwhile if you could just reiterate those for everyone.
Yes, absolutely. And apologies for the whiplash as I circle back through slides here. But I think I'm really glad that you brought that up. Just for the very reason that compliance is no longer, it's no longer, I don't know if it was ever optional, but compliance is important at this point because that data management and sharing plan becomes a term and condition of your notice of award. This is something that's going to be assessed on a regular basis. This is now part of the review process as you go through standard yearly reporting or periodic reporting. This is going to be looked for. Compliance with your process is going to be evaluated, and this can actually lead to outcomes that you may not like, including additional terms and conditions being applied to your award, can actually lead as far as termination of your award, and could certainly affect future funding decisions. Now, I don't know how far that will go. This is a relatively new policy, and I'm curious to see exactly how NIH continues to roll with this policy. I think the important consideration here is there's very much a movement within NIH to ensure data is usable and reusable, and that findings are replicable and reproducible. This is not going away. If anything, I can see, and this is my own looking at the crystal ball. This is nothing I know about what's coming down the pike, but I can very much see stronger and stronger support for this kind of DMS reporting, to making sure that your data is actually reusable, making sure that data is being shared. NIH wants to see this happen. So this is an important part.
Thank you, Brad.
Sure.
I have one more question. When I give data, in this data sharing as an investigator is I have images. I may have annotations. I hopefully have clinical or demographic data, because images on their own are not useful unless you have some metadata with them.
Sure.
What about derived data? Say, my grant was about pulling off a characteristic of chest radiographs. And so I have a quantitative, maybe semi-quantitative biomarker type value. Can I include that as metadata?
Yeah, that's a great question. I think a lot of what it comes down to is what counts as scientific data. So if that derived information is necessary to validate and replicate the research findings, let's say you have a probabilistic model, and to get to your intermediate image that you're using to generate your research findings that were published, you used a particular probabilistic model where you can run your model 10 times and you don't get the same result every time. In that situation, those intermediate images may actually be considered scientific data necessary for replication of the research findings. There may be situations where, I have a very deterministic, when I run this pipeline, I get the same outcome, within six sig figs or something. Maybe then the intermediate information is not as necessary because we have a really good replicable pipeline that we're running on that data. So I think it does need to be evaluated on a case-by-case basis. Certainly when we're thinking about something like neuroimaging, right? MRI pipelines are very different in terms of brain masking and how you may be annotating certain areas of the brain. Some of those intermediate findings may be valid as scientific data and maybe something that we want to see shared. I think if there's any question, certainly go to your PO and ask the PO what they see as necessary. Because in many ways, the more data that you want to share, the stronger the burden potentially on the group for data sharing, the higher DMS costs might need to be, depending on where you're storing the data, et cetera. So certainly worth exploring, but I think in the end, it all comes back to what's required to validate and replicate the research findings.
Thank you. I think this is so important. I know we're coming to the end here of our 45 minutes, but I really appreciate you pointing out that MIDRC is going beyond COVID. COVID was the use case to build this infrastructure. And for now, not as major effort as it was to build it, but to modify it now, we can expand it to other diseases, other modalities, imaging modalities. So I appreciate your comment on the use cases. Any closing remarks, Brad, before we end?
Yeah, I think maybe just two. The first is visit sharing.nih.gov. Evaluate, what is necessary, what's good for my data. I think it's important to be considering these questions. It's important to be thinking about, where does my data go? We don't want to be thinking about this as an archival process. We want to be thinking about data as a living, breathing, this is something that we will continue to use that has value. So think about that when you're thinking about your repository that you're going to select. And certainly check out the MIDRC NIH data sharing response. Check out this page. Contact the MIDRC team. NIBIB is very supportive of MIDRC. We want to see MIDRC continue to grow beyond COVID. And I'm sure we'd love to see your data in MIDRC.
Wonderful. Thank you, Brad. Thank you, NIBIB. And see you all at the end of summer. MIDRC will not have seminars in the next 2 months, but we'll be back. Thank you.
Thank you.
Thanks, Brad.